Ed.
Thank you. First of all, thank you for the invitation to share my observations today. Most of you know I've spent the last 25 years or so in health workforce planning and health workforce data, many years in New York State, and then 6.5 years at the AAMC, and then 3.5 years at HRSA, and then now at GW. So I looked at it very much from the perspective of what does it contribute to our abilities around health workforce data and planning and information. So I want to share some observations based from that very quick review, that the 24 hours or so that we had to look over the report. First, in my sense, is the report is really very well written, it's well thought out, it's well documented. It presents a strong case for the need for change and for the recommendations that they present. And the members of the committee and the IOM are to be commended for their hard work, their vision, and a very high quality report. Second, as documented in the report, I think this is really important. My sense is the current system is really unsustainable, our current system for funding GME. As we reform and transform the delivery system with the greater focus on efficiency, quality, and outcome, using inpatient days for senior citizens as the basis for GME reimbursement becomes even more illogical. The current Rube Goldberg system of financing GME also has many negative consequences, both for the efforts to reform healthcare delivery and the education and training of physicians. Healthcare is moving into the community, but our GME financing and medical training system is tied to inpatient care, and there is a danger that it will be left behind. Third, the report presents clear recommendations for future action and provides a roadmap for the nation. It doesn't present every detail, and there's going to be lots of room for people to say, what does this mean? They decided, and I think appropriately, not to go into trying to provide every detail for these recommendations. This really is the roadmap and the direction to go in. I think it provides a solid conceptual and practical framework for a far improved system of GME payment and policies. Let me talk some about the health workforce perspective. The IOM committee concludes, and correctly in my opinion, that we do not need more GME slots in order to meet our future healthcare needs. Having been responsible for overseeing both the original AAMC projections and the more recent HRSA projections on the adequacy of the future physician supply, I have a good understanding of the numbers and the factors that are likely to drive future supply and demand. Based on a review of the recent data and literature and recent developments, I now believe that redesigning the service delivery system to increase efficiency, improve outcome, and constrain costs will reduce the number of physicians we will need in the future below what we had previously anticipated. So I really believe the current level of GME production nationally appears sufficient to meet our future needs. Physicians play a unique and central role in healthcare, but the growing supply of NPs, PAs, pharmacists, RNs, PTs, OTs, and others working with physicians will help meet our future needs. In fact, I think training all of our new physicians to work effectively in teams with those other health professionals will have a far greater long-range impact on access and quality than adding a few thousand more GME slots. As a nation, we have to address the serious problem of maldistribution, but training more physicians and hoping they trickle down to high-need areas is not an effective strategy for meeting our needs. So there are some geographical areas and specialties where expansion of GME is appropriate and probably urgently needed, but any expansion has to be targeted. The proposed transformation fund would support the type of highly targeted investment and expansion to meet our documented needs. The proposed methodology would also remove the cap on slots covered residency slots covered by Medicare within the framework of the cap on overall expenditures. The report also recommends an expansion in data reporting and greater transparency for GME. In my mind, that's essential for an effective long-term system. I think it's important to point out that while the title talked about financing and governance, it was about governance as it relates to financing. And the recommendations, I think, appropriately recognize that the oversight of GME and medical education more broadly is really a shared public and private partnership. And so the recommendations don't do anything to disrupt the historical roles of organizations like the ACGME, the ABMS, the FSMB. And it's really worth noting that those organizations, and I'm very familiar with the really good work of the ACGME and the work that the ABMS is doing, but the work of the FSMB, the AAMC, ACOM, and the AMA really focus these days on what can be done to change medical education to improve the quality of the physicians that we are educating and training. And there's nothing in this report that would disrupt those current efforts. Again, I see this as a really public-private partnership, and I think the report effectively identified what's the public role here and what's the reasonable private role. I think the recommendation would foster a system that would allow for closer alignment between the nation's needs and the production of physicians. But it does it through guidance. It's important to note it does it through guidance and incentives. This, I want to be clear, in my mind, this is not a big government proposal. This isn't centralized planning. This is really calling for the federal government to be a good steward of the $15 billion that we now spend, the vast majority of which are federal and state funds and taxpayer funds. So again, don't be swayed, but someone said this is a major new bureaucracy. This isn't a major new bureaucracy. This is really a good government, responsible government. As I mentioned, while the report contains extensive information and explanations for its recommendations, there are many, many details to be worked out. Much work needs to be done to convert this report into meaningful legislation and convert that legislation into meaningful action. These will be challenging both technically and politically, but I believe that it is the appropriate direction. And I hope there is support for the next step of filling out the details. Finally, I know that this report will make many in the hospital and academic medicine community uncomfortable, including many of my old friends and colleagues. I urge them to read the report carefully, try and ignore the spin and the headlines, look at the details of the report and really the significant work done over the past 2 years. And I think there are two main takeaway concepts that I would like people to think about. First, that there is much in the report that is positive for the hospital and medical education community. This includes a recommendation to maintain stable total funding for the next decade, the elimination of the GME cap, and making funds available for new and needed GME positions, the 10-year transition period, and I think most importantly, it really would create a framework for a more rational, justifiable, and defensible system. The reality is that the current system is really not sustainable in the long term, so you can wait and say, let's do nothing for another 5 years and let it collapse, or you can look forward to really trying to implement some of the recommendations. The second point on that same note is that as I mentioned, the system is really non-sustainable. Funding GME based on inpatient days for Medicare patients makes little sense in an era when the nation is moving care to lower-cost ambulatory care settings and strongly encouraging efficiency. I don't know about you guys, but if you've ever tried to explain how we actually fund GME to someone who's not doesn't have a doctorate or hasn't spent 20 years in the field, you know that this is really, really hard to explain. It is, in fact, hard to understand. And people ask me questions about, does it do this or does it do that? And I must admit, I usually have to go back to see what it actually does. The committee recommended a far simpler, more easily understandable, and I think more defensible methodology for the nation. Efforts to promote ACOs, reduce readmissions, encourage prevention, delivery system reform are beginning to show positive effects. The hospital and academic community are to be commended because they really have invested, I think, incredibly positive time and effort to supporting reform of healthcare delivery. So the question in part, so why would we want to hold on to an outdated, difficult to defend, dysfunctional method of funding GME? I think the academic and hospital communities see the need for change. This report points a direction. You know, to be clear that it doesn't include all the, as I said, all the details, so there is opportunity, there will be many opportunities undoubtedly for the community to suggest improvements and changes. But again, I urge the community to view this as a positive opportunity. Finally, much work needs to be done. The IOM report is an important step in the right direction. I hope policymakers and hospital and academic medicine community view this as an opportunity to build a more rational and sustainable system to better serve the nation in the future. Thank you.
Great.